Good evening. Today let's see about the respiratory conditions. First we will analyze the ABGs. In ABGs we have a normal ABG, acidosis and alkalosis. In acidosis and alkalosis we have respiratory and metabolic acidosis. The normal ABG is pH 7.35 to 45, PCO to 35 to 45, bicarbonate 22 to 26. The pH and sodium carbohydrate will say us the different respiratory conditions in the person, like the person getting into the ARDS, the patient going to the asthma, patient with COPD, all the things will be differentiated and we will do the treatment. In acidosis of respiratory, you will see carbohydrate will go up, pH will go down. If the pH is normal, it is an uncompensated respiratory acidosis. If the carbohydrate go down and pH will go up, it is an respiratory alkalosis. In bicarbonate, it is different. If it is going down, then it is an acidosis, and if it goes up, it is an alkalosis. We can see mostly these conditions in extreme anxiety, fever and pain, respiratory alkalosis. Acidosis, as I mentioned, COPD, respiratory failure, pulmonary, pneumothorax, all these conditions. Management, we need to make the patient in alkalosis to receive and retain the carbon dioxide, and in the acidosis we need to remove the carbon dioxide by increasing the PEEP and making the patient to give a high respiration rate and release the carbon dioxide outside and retain the oxygen in the patient lungs, alveoli. Acid-base balance, the next is metabolic acidosis and alkalosis. Acidosis can be seen as it is decreased bicarbonate. We can see with a patient with colostomy, diarrhea, the patient who just completed a aggressive dialysis, extreme diuretics has been taken, all these conditions. And in alkalosis, we can see if the patient didn't do the dialysis or the patient is having any kind of pyloric syndromes, all these things, the patient will have a alkalosis conditions. Atelectasis, collapse of lungs, mostly seen with an excessive secretions and obstruct lungs. Signs and symptoms, pleural pain, cough, dyspnea. Management, airway clearance, positioning, ambulation, coughing and deep breathing exercise, spirometry, chest percussion and suction. Pneumonia, we have three types of pneumonia. First one is community acquired, second one hospital acquired, third one aspiration. Aspiration pneumonia are common in neonate, infant and in old age due to the aspiration of any food particles or their own any kind of gastric juices. When the patient is not able to digest it or the patient is throwing it out, this moment by mistakenly from the esophagus, if the food passages to the trachea, this is a cause of aspiration pneumonia. Ventilator associated pneumonia, the patient after admitting to the hospital dependent on oxygen needs and developing any kind of pneumonia, that is an ventilator associated or hospital nosocomial pneumonia. Then community acquired, the patient received the infection from outside the hospital before the admission of the hospital, is an community acquired pneumonia. Signs and symptoms, green rusty sputum, crackle sound. Causes, as we discussed, there are multiple causes for multiple conditions. Management, head and elevation, side lying position to prevent further pressure on the infected lungs. Suction, NG tube to prevent aspiration, IV fluids to balance their hypolimic shock. Tuberculosis. Mycobacterium tuberculosis is an organism which is causing tuberculosis. When the sputum culture turns out to be positive growth, active growth of tuberculi is an tuberculosis. Signs and symptoms, night sweating, weight loss, hemoptysis, productive cough. Diagnostic test, sputum test. Sputum culture is a confirmatory test. Before to that, we will do X-ray, AFB test. 3 days early morning, sputum will be sent for AFB test and then Montax test. If it is 5 mm, unless it is suspected, if it is more than 5 mm, is suspected, less than 5 mm is not suspected. 10 mm plus if there is an intradermal lump, you will find out that is an positive tuberculosis. If it is 15 mm, then it is an positive HIV. Some of the medications, rifampicin, ethambutol, pyrazinamide, isoniazid and streptomycin, vitamin B6 and increased fluids. Chronic obstructive pulmonary disorder, where the patient will be not exhaling complete carbon dioxide outside and they are not able to do it, that is an chronic obstructive pulmonary disorder. In this condition, we will give a patient moistured oxygen but not too much oxygen. The patient has a limited oxygen consumption because of cor pulmonale. The pulmonalis are being occupied with an excessive carbon dioxide. These patients need to be given with an high peak pressure, positive and expiratory pressure, to remove their carbon dioxide and to increase their breathing patterns. In this condition, we will give the patient bronchodilators and we will support them with an antibiotics to make them feel comfortable. We need to avoid these patients going from crowded places, and we need to provide them always warm environment and warm things to prevent any kind of distress. We need to give this patient high calorie and high protein diet. We need to reduce their physical activity. We have chest injuries, pneumothorax, hemothorax and flail chest. Pneumothorax, air in the pleural cavity, hemothorax, blood in the pleural cavity, flail chest. 3 or more ribs will be broken into 2 pieces. All these 3 conditions are most common in a blunt injury or in a patient with any kind of RTAs or fallen down patient. In these conditions, pneumothorax is very common with an old age patient. Example, any patient who is immobilized and they are long term bedridden, they are high risk for pneumothorax. All the 3 conditions we will go for ICD insertion if it is like more than expected for life-saving conditions. The patient will have a signs and symptoms of air hunger, chest expansion, diminished breathing sound. They will have chest pain, discomfort, and breathing sounds will be very diminished. We can see also the paradoxical respiration and diminished breathing sound. What is paradoxical respiration? The patient will use all the accessory muscles and nasal flares for the breathing. We want to give the pneumothorax and hemothorax chest tube insertion, thoracotomy if more than 1000 ml of fluid in the thoracic cavity. Flail chest, we will put a gentle pressure Vaseline gauze to prevent the patient from pneumothorax also here, and 3-sided occlusion dressing. So this is the pneumothorax, hemothorax and flail chest. You can see here 3 bones broken into 2 pieces. Ventilator. In ventilator, we have some alarms like low pressure alarm, high pressure alarm. Low pressure alarm always connected to patient. High pressure alarm always connected to the ventilator. Low pressure alarms like the patient is biting the tube, the patient is died, all this condition, the patient is not breathing. High pressure alarm, the tube is kinked, there is a secretion, the peak pressure is high. All these things comes for high pressure alarms. Management, we need to check the alarm and we need to check what causes the alarm. If it is a machine problem, change the machine. If you cannot able to rule out, immediately if the patient is going to the depress, give the patient oxygen by ambuvac and change the ventilator. Always we will do the hyperoxygenation. We need to be very cautious with oxygen toxicity. Intercostal drainage indications, pneumothorax, hemothorax or flail chest. Chambers are 3, collection chamber, water seal and suction. Normal findings, there will be intermittent bubbling in a water chamber and the continuous bubbling in a suction chamber and fluctuation. Abnormal finding, continuous bubbling, water seal, air leakage, absence of fluctuation and air obstructions. Some of the nursing assessment we will do, that is respiration rate, saturation, rhythms. In rhythms we will see percussion, dull sound, hemothorax and pneumothorax. Hyper-resonating sound, pneumothorax, auscultating, wheezing sound, asthma, COPD, crackles, pneumonia or pulmonary edema, absent lung sound, pneumothorax, hemothorax, emphysema, flail chest, and atelectasis. Positioning of the patient, always we will give the patient high Fowler's position or the bending forward position. No clampings, deep exhale and Valsalva. Please let us know if any doubts. Thank you.